So good morning, good afternoon, good evening, and good night for certain people from Commonwealth countries where they are there in the video also. And on behalf of the DCCC Center Climate Change and the Indian National Chapter of the ComHAD, Commonwealth Countries, India Chapter, and Lakeside Education Trust, we are organizing 21st monthly program here. And this month is the National Traumatic Brain Injury Awareness Month. In this context, we have selected the topic, how can we prevent to manage traumatic brain injury? This is what we have selected. And in the absence of our chief, Professor Satish, I request Professor J. Srinivasan, and we all know about J. Srinivasan, is the founder of the DCCC Center Climate Change and the chairman from 2009 to 2016. And also he is the honorary president of the Center for Atmospheric and Oceanic Studies, Institute of Science till date. And what I would like to say that he's a man with values, simple man, encourages always the science related issue and shares with us. And also he is a man, what he preaches, he practices. This is the day of climate change. Everybody wants to cut down the carbon footprint. He is the man cut down the carbon footprint. How he uses he don't have the car. He comes in the commute with the bus. And from Indian science to here in the bicycle he comes. So if you don't have any car, you will save 2 tons of carbon dioxide production per year. That's what everybody wants it. Individually, you have to reduce carbon footprint 2 tons per year. He's been doing it. And I feel very proud. That's why we nicknamed as a carbon footprint man of the DCCC. And also, he has done his own way of what he is today. And we are proud to share with him. And also, his late Sir C.V. Raman was his uncle. So, with few things, I request Professor J. Srinivasan officially invite our guest and all the members here. So thank you very much, sir. After to you, sir.
Good afternoon. On behalf of Professor S. A. Satish, a great pleasure in inviting all of you to this monthly program we have, in which Dr. Paramesh invites eminent doctors to talk on various issues related to health and environment. And we are very happy today that Dr. Ravi Gopal Verma, an eminent neurologist and also director of the Global Center for Excellence in Neurosciences, is come here to give a talk on how to diagnose and manage head injury. I would like to request Dr. Paramesh to introduce him. I just want to add one word. You've been saying all the days that I come by bus. I have stopped it after COVID. I cannot drive a bus and I walk. I don't use cycle anymore.
So before I just introduce the speaker, I just want to give some brief about the topic. So overhead of that one. And head trauma with brain injury is a leading cause for the morbidity, mortality, disability, and socio-economic burden globally. 1.5 to 2 million people are injured, with 1 million deaths in India. And it was plateaued during COVID. Now it is catching up again. Nearly 60% are from the road traffic accident, followed by falls, but that's about 25%. Then violence, 10%. And in these accidents, alcohol consumption is noted in 15 to 20% of the head injuries. WHO predicted earlier that the head injury will increase by 20% by 2020. Some of the studies from the Rajasthan have shown in India it has increased 147%. And that is from the road traffic accident in India. 25% are from the pedestrians. 17% is the motorcyclists. 15% is the four-wheelers, 10% are cyclists. And the rehabilitation needs of brain injured person are significantly high and increasing over the years and year after year. We are facing major challenges in prevention, pre-hospital care, how to transport the patient, not to touch, bending the head and all those things. And changing the environment, save the lives and the quality of life. To talk about this subject, we have most eminent person amongst us. That is Dr. Ravi Gopal Verma. He did his MBBS, MS, MCH in neurosurgery, and he's also a fellow of the FFSN. He is currently the director of Aster Global Institute of Neurosciences at Aster Hospital. He was earlier the professor and the head of the neurosurgery since 2008 at Ramaya Medical College. Initiated deep brain stimulation program for Parkinson's disease in NIMS Hyderabad. And he served as a member of the board of studies NIMHANS for 3 years. He's a visiting professor at Sir C.V. Raman Research Institute. And he is the first person to introduce deep brain and stimulation surgery, neuroanthrocytosis site in India, and the third in the world. He has published many scientific papers which are peer reviewed in many journals, contributed many textbooks, and received many awards locally, nationally, internationally for his work. And his statement is, brain is life, life is brain. This statement, one of the statements I read about it. And more than that, I want to say a few things myself. His father was a dear friend of mine. He was my teacher, Professor Ravi Verma. We were in the ComHead together. We traveled to Geneva for a couple of times. We're very good friends. And he the one started NIMHANS. Earlier it is called National Institute of Mental Health. Mental Health, started by Govindraj. Govindraj, M.E. Govindraj. And the logo is swan, swimming. Swan is like a smoothly floats in the water during the moonshine. But his legs are always working hard. So mental patient may look calm, quiet, but they have a lot of turbulence inside. The water was turbulent. So very near to that one, there is a lotus. It is going to bloom in the morning when the sunshine comes, waiting for it. So I think we are all the mental people, look calm, but assess them first. And there is always a help, just like a lotus we are. So that National Institute of Mental Health became NIMHANS with his father only. He brought that name, anything like that. We are very proud to say that. And NIMHANS word coming from the Sanskrit. It's called Hamsa. Hamsa, I am there at. I am there at. That in Sanskrit it means. How do you say Hamsa? If you keep rapidly telling it loudly, Hamsa, 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 Vamsa, it comes there. Somehow, or like it comes like Mara, 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 you call Rama. Same thing, it comes like that. That is what the word came from the origin of the Sanskrit. This is what I heard from your father. So these are all the issues, and we miss him in one of the great person we had. And also hails from the Ravi Verma family. Heard of an artist, King Raja Ravi Verma from Kerala. They are hailed from that family. With this background, and as a simple man, I like him very much. And you can interact with him anywhere, anytime you can call him. We feel proud to have him here. Sir, it's over to you. Thank you.
Very good evening to all of you. I thank Dr. Parameshwar for his kind words and in his invitation. I have seen Dr. Parameshwar from when I was very small, and when I used to accompany my father, he used to operate in Lakeside Hospital also, and I used to sit outside the operation theatre waiting for him to come back. And then he used to come and give some sweet or chocolate or something. I remember very clearly to pamper me and let me sit there because I had to take my dad back. This was pre-MBBS. After that, I did MBBS, and then I visited the operation theatre and assisted my father a couple of times. I thank Dr. Srinivasan also for your kind words, sir. And I thank the DCC for inviting me for this talk. So as he had given a detailed outline on the statistics, head injury is something that we all see day in and day out. Many times we do not even recognize it's a head injury. Many a times we think it is the end of life. Having a head injury would be finished. We would be finished. So I think I'll just go through a few slides telling you about what the statistics, again, repeating those statistics. Then what we do, how to recognize a head injury and what we need to do at that point, even for a layperson, a person who has no idea but would be detrimental if they manhandle the patient. And bundle them up and put them in an auto and send them to the hospital. Very, very kind-hearted people would do that, but that would be detrimental for the patient. So one has to be very careful while handling a head injured patient. That is one. And then I'll talk a little about how it is to be managed and what is the pathophysiology and things like that, so that you will understand approximately. By the end of the talk, I think you should be a little more well versed with what head injury is and maybe recognize what head injury is all about. So as the definition goes, it's a very broad term. Head injury is described as injury to the skull, the skin over the skull, it's a scalp, and the brain, blood vessels, or the head. All these things are within the head. In this, small, the skull occupies the brain, and brain is, if you do look at the connectivity in the brain, there are about 10 billion cells, and each cell has at least 3 to 4 connections. So that is 30 to 40 trillion connections. So that is the phenomenal activity the brain does. And if you convert it into a computer, even in the latest computer with all the chips, it would occupy half this room to fit in all the functions. And when I say all the functions, it's 10% of the functions we know. 90% of the brain is unknown. There are areas which we have no idea what they do, what they function, how they work. You might have seen people levitating, you sadhus walking on water, some people talking to you about the future, very precisely and accurately. They use the different modalities of shells, or they use the different modalities of stones. They use different mathematical calculations, astrology, etc., etc. And they predict. Now that is one part of the brain. You can't say it is wrong, but we have not proved many of these things. When you can walk or levitate, that means you meditate and you go up against gravity. This is a function of the brain, but we do not know. Everyone can't do it, but there's nobody who can't do it, because there is a part which we have not analyzed, we have not studied. So this is how magnificent the brain is. And when you have such a magnificent organ within you, it is nicely, compactly, well, protected in the skull, and it floats in what's called CSF, cerebrospinal fluid. Otherwise, it would be very difficult for us to walk around, because it is about 1.5 to 2 kgs. But because of the CSF, that is the cerebrospinal fluid, and the buoyancy of CSF, it is effective to about a few grams, 500 grams, 400 to 500 grams. So that is how this whole mechanism has been suspended in our body by some great architect. So having said all this about the brain, it is very, very important for us to protect the brain. Because as I always say, brain is the master of your body. It controls your heart, it controls your kidney, it controls every bit of your body. But having said that, it is also a slave. Because if there's an issue with the kidney, or issue with your liver, or issue with your peripheral nerves, the brain is going to get affected. So it's a very dynamic situation there where it rules, but it's a slave. Because unless the kidney performs well or the liver performs well, the brain cannot perform. And for these two to perform well, there should be a connection with the brain. So that is the intimate connection with body and the brain. And then there's one very wonderful thing. Again, we don't know where it lies, is the mind. Whether it's in the brain, it's in the heart, it's elsewhere in the body, we do not know. It could be somewhere. But there is something called mind, which we all know. Is it individual to a person? Maybe individual to a person. Some people have a different, mentalities change. That doesn't mean that it's a different brain. Anatomically, it's the same thing, but functionality is different. So this is how magnificent the brain is, and this is where protecting the brain is very important. When you ask a person to wear a helmet to protect your skull, they're worried about the hairstyle. They keep it on under their arm and drive the bike. They keep the helmet at the back. And when they see a cop, they put. I don't understand. The cop has nothing to do with the beautiful structure that you have inside your skull. We want to protect that. And it's been proved over and over again that helmet does protect the brain. Small injuries. It's not a massive injury where a lorry runs over you. Poor helmet can't do anything about it. But if you just have a small fall and hit this part of the brain onto the pavement or onto the curb, I have seen instantaneous death. I've seen death happening in 2 hours, 3 hours. There's something called lucid interval, where you get hit, you are fine, you lose consciousness for a moment, you're fine, you get up, you go to your hostel, have your dinner, and you sleep, never to wake up next morning. So that's called an extradural hematoma, which can slowly collect within, and when you're sleeping, you don't realize. And in the morning, somebody wakes you up and you're not waking up. You do an autopsy, you have a large. So that is how important it is to look after your brain, because your brain is the master and the slave at the same time. You've seen this so many times. This never happens in countries where these rules and regulations are followed clearly. This one small bump, one of them can pop off. Forget a bump. When you have a little pothole, they can fall. And they can fall and another vehicle can go over them. We have seen that happening on Bell Road. There were huge humps. Now, luckily, they made it small. And the traffic was not very much when I used to work in Ramaya. There, an 18-year-old engineering girl, I remember, going for an exam, was sitting at the back, and the brother was dropping her to Ramaya Engineering College. Bump came and she fell back. And she was in the hospital for 1 year. Luckily, for reasons I will be telling you, she recovered. She had a tracheostomy. She had a big surgery. Half her brain was contused. We had to remove a lot of brain. She had weakness on one side, but she fought back, and you see how beautiful the brain is. She recovered to finish engineering, and now she works in Microsoft with half a brain. The brother had come to the operation theatre when we were removing the clot, and we spoke to them that she's very critical, but we're going to take her for surgery. And then he opens a small newspaper packet and says, and I saw some gooey stuff there. He said, this is the brain that fell out. Can you put it back? So in such a patient, the brain recovered. The primary insult was there. We prevented the secondary injury and the patient improved. So we really don't need full brain to be functional and become an engineer and doctor and practice and all that. But when you have a full brain, it's totally different. So please protect your brain. So that's very, very important. So most people don't know brain injuries, let alone the consequences. What is head injury? Falling. For example, a cricket player can have a ball injury, or a boxer can get hit on the head. Small little shots causes microvascular damage to the brain. It won't happen, it won't show immediately, but 10 years down the line, 15 years down the line, you will know about it. People who play rugby, contact sports, there are issues when they have what's called concussive head injury, post-concussive syndromes. So it's very, very important to look after your brain and to take it to the next level. Who are the highest risks for having head injury? As always, males have 1.5 times more likely than females. There are no statistics to study why it is so, but there are a few things that is it. One of the things which, on a lighter note, the female skulls are thicker than the male skulls. So the female brains are smaller than the male brains. But that's not a bad thing at all, because the amount of connectivity is far more than males. So their little brains can function far better than the male brain. So, but if you look at the thickness of bone, definitely so that protects. It's like a double helmet sort of thing, So females are less common sustaining traumatic brain injury. So the two most common groups that are at risk are 0 to 5 years to 15 to 19 years old, and then the elderly, because they're all very susceptible. Children are very susceptible to have a fall and a break and a head injury because their bones are very thin, not developed as yet. Infants to about 5 years. 18 to 19, I think it's the adolescent period when they're a little more loose in their, they're a little more aggressive, they're a little more adventurous tendencies to have injuries. And 75 and above is because of falls. So I'm very happy that you don't cycle nowadays, because however well you cycle, if somebody just taps you, you will have an injury. So walking is safe. Nowadays, I'm not very sure, but still, if there's a good footpath, which is sometimes non-existent, it's a good way to, look after, protect yourself. Never feel ashamed to carry a stick if necessary, a tripod stick above somebody. Because I know it feels, oh no, I'm not dependent on a stick, but it's not dependent. You can leave it standing, but if it's there, you always have a tendency to grip on something before you. So don't hesitate to carry a tripod if you're beyond 75. I'm just generalizing. There are people who are really fit at 75 and who is running marathons at 75. I'm not talking about that, but the general public, because our reflexes become a little slower. Our cerebellum, the brain, starts shrinking a little. So all these can contribute to instability, and then a small stone or a little misstep can lead into a head injury. And because of this gap between the skull and the brain, as my father always said, it's not the brain is shrinking. As you grow older, you need little of the brain. You don't need all the brain. So it just becomes a little smaller. And there's no negative thing there. But there's a gap between the brain and the skull and the dura. So there are some small blood vessels there which can bleed once in a way. So if you have repeated trauma, it can cause what's called a subdument, which will cumulatively over 2 to 3 weeks, it can collect. And you might come with a headache or a weakness on one side, etc. So again, elderly needs to be very, very preventive in these things. Again, I think Dr. Parmeshwar clearly told about what are the commonest ones, and of course, road traffic is the commonest. It's about 60 to 65%. Falls are about 20-25. Violence, hitting on the head, all that is about that much. And violence is a lot of violence these days. I'm not talking about the violence that you have with mobs and things like that, but even battered baby syndrome. This is very common in children. And the mother and father are working. They leave the child with the maid. The maid is really not bothered. They keep hitting the child. And child does not affect the child immediately, but shakes the child. It's called the shaken child syndrome. Slowly, the brain starts having issues. And there'll be small telltale evidences that this is happening. Another thing that happens to children is in falls. The father and mother again are going to work, and luckily they have their parents who look after the children, but the reflexes are not as fast as the 4-year-old or a 3-year-old. And we have seen so many patients, especially during rainy season, falling from the balcony, children. And so balcony heights are, stylish balconies have low grills. So and very wide grills just to keep in vogue with the style. But that is enough for a little toddler to slip across and fall down. And the grandmother, whatever she tries, or a father, whatever they try, their reflexes are not good enough to keep up. So they tend to fall. So we need to prevent those things also. And these type of head injuries are very common. 56,000 people die in a year due to head injuries. And there are about 2,90,000 people who are hospitalized. And there are nearly about 12,24,000 who are treated and released in an emergency department. In children, according to the Brain Injury Association, it's the leading cause of death and disability in children. One child falls and then has a weakness. That weakness is there. Child will not improve, and then throughout the life, the child is going to have that issue. And we really don't realize that if a 25 or 30-year-old something happens, they can work on it, but the child will never work on it. I mean, they don't know, they ignore it, and they live with it with a smiling face because they don't know what could this help of a hand would have been if the hand was fine. It was throughout there with. But we as parents, when we look at a child growing like that with no upper limb or no right leg, or no activity on the left hand, or no speech for that matter, it's such a traumatic thing for us. So it's very important again to prevent these things. Brain injuries account for over 90% of any emergency. You look at any emergency, the children's emergency is full of children from 0 to 14, and that is 90% of them. So your fevers, your colds, your coughs are not common. Falls, trauma, injury, these are common in children. So sports injury, it's a big thing. Sports, everyone wants sports. They don't train adequately and they go to sports which require extensive training, extensive physical endurance. And you land up with injuries, you land up with head injuries and things like that. As I was telling you, football, one header goalie, if he heads goal, that causes at least 5 to 10 million cells to get disrupted. So each neuron, if you look at the anatomy of neuron, it's like a cauliflower. And the cauliflower stumps are the axons, and the cauliflower is axon is the cauliflower. And the thing that connects the cauliflower is called the dendroids. So nucleus is there and the dendroids are there, the axons are there. So if you shake cauliflower, what happens? They break at where the flower connects to the stem. That same thing happens to a neuron. So neuron is like that. This is the cell body of the neuron and this is the connector. They disconnect. And once disconnects, it's not like the liver or the kidney where it can regenerate. Brain does not regenerate. So it remains there as scar tissue. So that many cells do not function. That is why we have about so many billion cells. Because however we misbehave, there is some adjustment done by the architect of the brain, where you are able to continue functioning, becoming normal, doing everything, and with a few thousand or few million cells dead. But it is. But what happens if it's cumulative, repeated injuries? You can get into issues. And that will show not now, 15, 20 years from now. So your silent head injuries keep going on and on and on forward. So this is the National Football League. There are about 5,650 head injuries in youth seen in every probably in a month or any game, in a single game all over the world. If you have multiple people are playing, there's concussion, so much of concussion that happens. And therefore, it's very important for you to learn, if you don't want your head to shake with your brain, irrespective, your neck muscle should be strong. You should train yourself to avoid injuries without avoiding injury to the brain. So that is where endurance, scientific management of sports and sports, the sports medicine is coming in a big way, because we don't realize these head injuries because they just accumulate and cause issues. And therefore, it's very, very important that sports injuries to be prevented, especially when the head is concerned. So No brain injury is too mild to ignore or too severe to lose hope. It's very, very important. As I told you, small hits. Patient is absolutely fine. I mean, a boy or the person is absolutely fine, but it is injured the brain. There is some injury. There is some cell loss. It might show in scholastics. You know, some sports people are not. They don't study too well because there are certain areas of the brain that assimilate knowledge is not functioning to the optimum. So you see, he's dumb, but he's very good in sports. He's not dumb. He's because of constant badgering. They call the intelligence quotient, which is an old technology. I mean, to assess brain strength. But though now there's a lot of controversy on that. But the general apathy, anger issues, children have, sports people have. So these are because of bad management of your sports technique, which is very, very important. And you can have very severe injuries, like I told you about that lady. 1.5 months on ventilator, 2 months on tracheostomy tube. Life was given up, hope was given up, but then she did an injury. Now she's married and probably she's going to have a child, because I went for a marriage 3 weeks back. So that is how it is. So whatever it is, you need to treat head injury. What does it happen? What happens to head injury? As I told you, the whole skull and the brain has a potential space in between called the subdural space. So there is a skull, there is a dura, which is the covering of the brain, and there's brain. And the brain is a fluid, as I told you. So if you have heavy injury on, this is a coup and contra coup. So you hit it, there is injury at that spot, but not only that spot, you have injury on the opposite side, because the brain goes in ricochets and hits on the skull and comes back. So that can be a coup. So you have an injury here, you'll see a swelling here, but you'll have a clot on the other side. So that is the mechanism of the primary and then the secondary. This is a broad classification of what head injury is. So mode, you can classify head injury as mode, that is accidental, non-accidental, or type, closed, blunt, non-missile, penetrating missile. And then you can have, depending on the severity, mild, moderate, severe, depending on pathophysiology, primary and immediate, secondary and delayed. So these are approximately how we classify, and distribution, focal injury or a diffuse injury. As I was telling you, the small neurons getting disconnected from their axons is a diffuse axon injury. So how do we assess when it comes to the hospital? From the point of injury on the road to the hospital, we need some tool by which we can assess what the prognosis is or assess the progression of an injury. So that is why we have something called the Glasgow Coma Score. This was developed by Teasdale and Janet, who were neurosurgeons in 1974. So this is very simple. You look at that. So even a nurse or an ambulance person, class 4 worker in the ambulance, a nurse, a junior doctor who goes with the ambulance, a senior doctor who's in the hospital, and the specialist, neurosurgeon, all will have a common tool for measurement of how bad the head injury is. That is a Glasgow Coma Score. It's very difficult, but this is one scale or one tool that is well accepted. So what is it? It's the eye response. Does he open his eyes when he's lying down there? If he's spontaneously opening, you give him 1 point. Sorry, it is 4 points. If he is only to speech, that means he's closing his eyes, you call him, he opens his eyes, but then goes back to sleep. If to speech, you give 3 points. If it is to pain, that means you have to pinch him to wake him up, given pain to wake him up. Or even if you pinch, there's no response. This is 1. So if we add everything, so if you and me at this point are 4 plus 5 plus 6, so that is GCS 15. So we write 15 by 15. That means all of us are GCS 15 by 15, where we are spontaneously opening eyes, we are oriented to time, place, and person. We obey commands. If you ask him to lift your hand, put your tongue out, you're going to do that. Next step is if you're confused, that means you wake up and he's asking, where am I? I don't know where I am. He's talking, he's opening his eyes, but he doesn't know where he is. Confused, and you give him a 4 point. Inappropriate words, that means unrelated. Some proper words, but not related to the situation. Then you give him a 3. If it is incomprehensible, that means some sounds makes nothing, it doesn't mean anything, you give him 2 points. And if there's no verbal response at all, you give him 1. And similarly on the commands, if he obeys commands, if he moves his limb, that means you pinch him and he is unconscious, but you ask him to move his hands, he's not going to move. But when you pinch him, he will take your hand away. So that is called localizing to pain. Flexion withdrawal, that means when you pinch, he flex, he's not trying to separate it, but he flexes out. It means more injury to the brain. And then you have abnormal flexion. That means your legs flex and the hand extends. That is the next stage of decortication. And abnormal extension is decerebration. That means the cerebrum is cutting away from the spinal cord. It means a really severe injury. Finally, no response. So GCS 3 is the lowest you can get, and GCS 15 is what you and me are at this point. And GCS 3 means there's no response. Then it's a grave injury. So depending on that, we can classify minimal, mild, moderate, severe, and critical. So those calculations are put 15 by 15 is minimal because there is head injury, but he's like you and me. So that's how it is. So if you are 13, 14, or 15 with temporary loss of memory or a brief loss of consciousness, was unconscious, then he wakes up, or if there's impaired alertness, then he goes to mild type of head injury. Moderate injury is more than 5 minutes, is unconscious, he has a focal deficit, maybe a weakness in the limb, or his GCS is between 9 and 12. And then severe is 5 to 8, critical is 3 to 4. That is how we can assess or diagnose head injury and severity. So what do we do? Depending on the severity, mild injuries are 80%. Luckily, we have a large number of people with mild head injuries. Moderate would be about 10 to 13%, and severe is about 7 to 10%. Now, mild brain injury, as we told, accounts for 90% of all brain injuries. It is known as concussion. Okay, concussive brain injury. These terminologies you'll hear, I'm sure if you have some relative or someone who's had an injury, these will be there on the discharge summary. Concussive head injury or subdural hematoma, extradural hematoma, these are the words that you'll hear. There is a brief period of loss of consciousness. There's a dazed, vacant stare after the injury, which improves. Then you will have all these physical signs of headache, vestibular symptoms, dizziness, ataxia. Ataxia means difficulty in standing, you wobble around, balance problems, visual disturbances, you see areas of blackness in your vision. These are complaints that they'll tell you. Or you have phonophobia. That means you hear sounds and you don't like to hear the sounds. These are all symptoms of the concussive head injury. And nausea, no vomiting, but nausea. And then you can have vomiting itself because the brain has gone into has been badly shaken, so that can alter your vestibular system, and you can have vomiting, nausea. Cognitive problems that you can have is difficulty in thinking, immediate injury. I'm talking about immediately after injury and a few days after. Difficulty in concentrating, feeling foggy, slow response at times. Relatives come and says he's good, but he's very slow. He's not. When you ask him a question, it takes much longer than before. All these things are bound to improve with time. And difficulty in recalling. And another beautiful thing is called the post-traumatic amnesia. That means you have some sort of a memory loss from before the trauma to after the trauma, which our Hindi movies take it in a big sense and make it dramatic. Months of amnesia, and suddenly somebody hits him again and he gets back his memory. It doesn't happen like that because amnesia, post-traumatic amnesia can occur, and you can have, it is a way of not remembering the traumatic part. So it's a protective mechanism by the brain and the body. Just imagine if you have been hit by a lorry, and every night it's a nightmare when you imagine what the lorry could have done. So before the lorry comes to when you're in the hospital is forgotten, because that is lost in your memory. And then, which is a good thing, because otherwise you have post-traumatic nightmares, which is worse than anything else, because every night you close your eyes, you see this lorry coming in hitting you. So that sort of the thing is, again, a body's mechanism to do. Emotional lability, little later, crying for no reason. Small things you start crying and you're depressed for unknown reasons. So all these are post-traumatic conditions. Then you will have drowsiness, you sleep, you sit and sleep when you're watching TV or something, which you normally don't do. All these things are reversible. In due course, they get better, they get better, the better as the brain heals. So again, often people with mild head injuries do not even go to the hospital or may not seek anything. They say a small thing, nothing's happening to me and all that. It's always better to go to a hospital and get that cleared. Because as I told you, there are chronic hematomas that come in, late hematomas that can come in. So better get it checked, doctor sees, examines you, maybe do a CT scan, which you know what is happening in your brain. And then you're comfortable. And then a week later or 2 weeks later, if you have any issues, you can check whether there's a change. Many signs and symptoms are similar to other problems, and so they will just ignore. Sleepiness I was having from the beginning, it's fine. But this sleepiness may be due to a hematoma growing in, may not be due to a regular sleepiness. So you need to be a little more concentrated, a little more sensitive to these changes post-traumatic. And the post-concussive syndrome, which I was just talking to you about, is something that can be from 2 to 3 days to about 2 to 3 months. You can have that. And usually most of them get over it by the end of that. If brain injury can occur even if there is no loss of consciousness. I didn't lose any consciousness. I was fine. Of course, it came and hit me, then I'm okay, a little unstable, but I didn't lose consciousness. I was fine. But that can slowly progress into a hematoma, or it can slowly progress into neuronal damage. Nothing we can do for the neuronal damage, but definitely for a hematoma or blood clot, we can do something. So that is why it's important to take an opinion. No harm in taking an opinion about whether it's okay. I just had this head injury. Come and see the physician. See him. He looks at you, fine. There are some telltale evidences which he can pick up, which you can't as a person. Brain injury can occur even if it's there without low of, as I told you that. Moderate brain injuries is one in which there is a loss of consciousness that lasts for a few minutes or a few hours, followed by, as I told you, days to weeks of post-concussive syndrome. Severe brain almost always prolonged unconsciousness is there. They go into what's called coma, and then lasting for weeks. I've seen people recovering from that. I've seen people who do not recover. 70 to 80% do not recover from that. But a good majority of nearly 20%, because for the 20% it's 100% recovery. So I can say the common question that people ask is, how is he going to survive? Will he survive? I'm not an astrologer, but I have to give him hope that he can, because there are 20 to 30% who survive from such bad head injury. Then that positivity comes in. And it's very important to be positive, because even when they recover, you need to be positive. You need to give them positive inputs, because there will be a period when they are not very conscious, according to us, but are hearing what's happening. They cannot react. But I have heard patients when they come out of coma saying, that sister said I'm going to die, but I'm okay. Because subconsciously, sister must have said, oh, you kate movie to papa. So when you talk like that, they are able to hear, some of them. So always when you're on rounds, you have to be positive. When you go to meet your patient who has head injury, talk positively, because at some point they will be able to connect, but they cannot react. Reaction comes later on. You might see sometimes they react with eyes watering of the eye. That is a way of reaction, because they're sad, but they cannot express, but eye water. So we have seen all these things in trauma. The guidelines of management mind head injury, as I told you, these are guidelines. So there's no neural. The most important thing is to see a doctor, because then he decides whether you need all this, whether you fall in group 0, group 1, or group 2. If it's group 0, if there's no radiological issues, etc., you've seen CT scan plus or minus depending on the neuroscience surgeon, you can go home. Radiology shows it's a CT is negative, but then you have other problems. Then you are admitted for 24 hours, because if there's a fracture, which is small, or there's a small clot, we would keep them for 24 hours, repeat the scan 24 hours later, and then decide to send. Because that clot can grow in 24 hours. So you observe the patient. Group 2 CT is always necessary, and so the groups are according to the GCS, severity of exact. In all groups, neurosurgical consultation is mandatory. Even a general physician is not enough, because there are not points that he cannot pick up. And so it has to be seen by a neurosurgeon. Doesn't matter Go and see him. He's not going to admit you if unnecessarily, but if there's something, they'll be able to catch it. Primary goals of management is very good. Is very important. The primary injury has happened. You can't reverse. You can't put a switch and reverse the whole thing. You have a bus going back and the bike coming straight and your helmet coming back. No. Once the injury happens, the injury happens. Subsequently, the secondary injury we have to provide. That means if somebody grabs you, and you've seen if one head injured patient is there are 50 people looking, they breathing down the head. One fellow with a video camera, another fellow with this. You're giving no oxygen for the patient to breathe. That will worsen the primary injury and you get secondary injury. So immediately clear people out. There should be 2 or 3 people who are going to assist, and nobody should be sitting around on top. So, as I told you, the secondary insult is the most important thing. We have to, a clot can occur. The clot can keep on increasing, compressing the brain. That is secondary injury. Remove the clot, secondary injury is prevented, and primary injury is taken care of. So it's very important that you do that. So small things, use helmet, use a seat belt. If you don't have if you have a seat belt and you don't put it on, even if you have an accident, your airbag will not open up. You have to put a seat belt. On a highway, pillion also should put a seat belt because highways are fast and what can happen to front 2 seat can happen at the back 2. Again, the seat belt will not open or the airbag will not open to protect you if you don't have a seat belt. Recently, a gynecologist and a husband was driving our person. Yeah, so he was sitting at the back without seat belt. The front 2 was safe because they had seat belts on. So never feel shy to wear a seat belt. Many people feel shy to wear a seat belt. Well, they put it at the back because the car beeps if the seat belt is not on. Don't do these things. Seat belts are very, very important. Prevention is very well. Helmet is very important. Drive safely. Look for potholes. Because if you're driving a scooter, which has a small wheel, and you fall in a pothole, that is the most dangerous thing that you can have. A bigger bike may not have that much of an effect, but certainly a smaller vehicle will have that effect. And if you take care, it's always better than cure. Take care, prevent these things. So global guidelines are there. No one is immune from getting head injury. I have never got, I will never get. Hopefully you will never get, but there is always a chance. Even the smallest mistakes that we do, we can get a head injury. No one, see the how do you manage? There's a pre-hospital management. In the pre-hospital management, the ambulance comes, trauma comes, the team comes. Before that, don't try to put them into an auto rickshaw and shift, bundle them. No, there is a board that comes because if you bundle them, there can be a spinal injury which was stable, which becomes unstable when you bend the neck. So your spinal cord, which was safe, becomes unsafe when you become quadriplegic. He was moving his leg when he was there, but when he brought him to the hospital, he's paralyzed from here down. That's why he was bundled. Let him remain flat. Call for the ambulance, see the ambulance comes. Till then, give air, check the pulse, check the heart rate, put your ear to see the heart rate. If it is there, wait, doesn't matter. He's not going to die from that. If his heart rate is not there, you do CPR and you could do other things. But otherwise, masterly inactivity till the trauma team comes is the most important thing. If there's some bleeding, put a bandage there. Doesn't matter of dirty linen or whatever little thing, tight. So the bleeding is reduced. So these are things that you should do because if bleeding continues, there'll be hypoxia, brain can get damaged, which wouldn't have get damaged if the bleeding was not there. The brain may not have got injured at all in an accident, but then do these things. And then once, give a lot of air, don't go around and sit around the patient. Then the patient goes to the hospital. When they come, they bring a board. The patient is log rolled, not folded, log rolled into a stretcher shifted to the car, into the ambulance, and from there taken to the hospital. From there, the monitoring happens. The GCS is noted. GCS is noted at that time. It's noted in the ambulance. It's noted on the way from the ambulance. Hourly, every 5-10 minutes, a chart is made. It reaches there, and then that's how one head injury has to be done. So the goal basically is to remove the patient from a hostile environment that is around there to a hospital environment. As fast as possible, as quick as possible, safely. That's the question. Don't roll him up and put him and take him. Prevention of hypoxia and hypovent. That's when the bleeding is there. Some bleeding, just stop it. We just give pressure, it'll stop. or tie a thread, it'll stop. A scarf or something like that, it'll stop. And then wait for the ambulance, and then it should happen. Cervical spine has to be immobilized. They will do it. They will come put a board so that you won't move your neck and you're shifted like a log. So the most important thing is to treat the primary injury, and then we prevent a secondary injury. Prevention of secondary is the most. So that can lead to a lot of rehabilitative issues and prolonged physical disability. Disability scores go very high. So it is. These are a few pictures which you have seen. You know, I've seen a patient who came with a screwdriver right through the eye, going down. You can see that. In that, a dagger from here to here. He was jabbed in with a dagger. Fully conscious, alert once the dagger is taken out. You can't just pull it out. We had to open the brain, then open the skull, and slowly pick it out with any vessel should not be involved. And then it happens in the operation theatre. Don't try to remove that knife. Oh, knife is there, pull it out. When he's going to die that moment there. Okay. These are few things, terminologies. The cerebral perfusion pressure, as the name indicates, it is the amount of blood that flows into the brain, which is important. So it is something that has to be maintained. The blood flow has to be maintained. Oxygen has to be maintained. And then there are medical management, the mannitol, Lasix. These are things that reduce the brain swelling. And steroids are not to be given in trauma because that can cause detrimental issues. Sedative medication are not to be given, especially at home or any place. We don't give sedatives because that can mask a progressive loss of consciousness due to trauma. So that has to be done. Mannitol is a drug that is commonly given to reduce this edema, and edema is swelling. As you know, the skull is a rigid and you have a brain there which is tightly coffeting. You have a clot there. The clot is an extra fellow, and that can compress the brain and compress the brain further. So we have to release the clot. So therefore, it's important to give mannitol. The pressure comes down, then we release the clot. And hyperventilation is another way of releasing. Hypothermia, making temperature low, again helps in better recovery and better, less of secondary injury. Seizures are important because if you get a seizure immediately, seizure is a fit or epileptic attack. We've seen many on the road get an epileptic attack after an accident. The medications has to be given accordingly. Don't stop the medications for a year till he settles down and things like that. So there are different types of seizures classification. Early seizures, immediate seizures have to be treated. Early seizures are okay. Late seizure again has to be treated. Surgical management is to bring the intracranial pressure down. Because as the pressure goes in a closed circumstance, environment, brain keeps increasing. There are few holes which get your spinal cord out, get your nerves out. The brain can get stuck there and you can have complications due to that. So ICP has to be, we remove the skull. Sometimes brain is so swollen, we remove the skull and leave it out so that the brain has time to expand. And then later on, when the brain becomes okay, after that, you put the skull back. It's called decompressive craniectomy. And effects of brain injury, as I told you, keep on. Time is very, very crucial. Time is brain, brain is time. We have to be quick when we do these things, and care has to be given immediately. There are people who have accidents, cars don't stop on the way. They die not because of the accident per se, but because of a clot which we could have prevented. 24 hours, 5 hours, 10 hours on the road, will die. Within an hour, if they're in the hospital, they live. So it's life and death, that is the difference. So never ignore and run away if you find someone on the road. I remember my father telling me one story. He was going to the Nandi Hills, and at the foothills, he saw an accident, a bike accident. So he was a neurosurgeon, so he could stop. He stopped, then he saw the pupil was a little different. One pupil is more dilated than the other. That happens when the clot is expanding inside. And he saw a cut there. He has no time from there to bring him there to the hospital and operate. So he used, olden days, you remember there used to be a hubcap in a car. And there was a small thing like that would bring the hubcap out. The sharp edge with a long metal. He put his thing there and opened the brain. Opened and let the clot out right there. And he immediately became conscious. Then shifted the patient to the hospital and then operated. So time is very, very important. Don't waste, you can't waste time in trauma. So as I was telling you, primary injury cannot be stopped. But secondary injury is something that we need to work against. I think with this, all of you are sleepy enough. I think I should stop. But then, most important thing is one terminology. Even the mildest of head injuries, you have to give importance. The most severe head injuries, you have to have hope. Thank you. I think I can take questions.
Yes, any question?
Yeah. No. Yeah. So luckily for me, I don't see the lorry coming and hitting the patient. Nor does the lorry hit me. But I see the clot. But then we get used to it because we look at the end. After removing the clot, if I see the patient going to be conscious with a smile, that is enough. It wipes out all little stress that we have. And I think over our training, we become more and more strong because we know what the outcome can be if something is done and if it is not done. So we are quite happy to do it. And I sleep well because the end result is important. Definitely, as human beings, there is going to be a point when you expect a patient to live and he doesn't. But then you have to get over it because you dwell in that and then you lose yourself, then you won't do benefit to another patient that comes. Because you have the memory of this whole patient. I said, oh my God, this I'm scared to touch. But we get trained, and I think with training and with some sort of experience, we get across that thing and we're able to manage it and self deal with it. Correct. Yeah. Snehha. Yeah. Yes. And the scan showed that portion not there. Even now it is not. No, she's certain faculties are not there, but that hasn't prevented her from finishing her engineering and working. But maybe if you look into going to dwell into the whole neuropsychological assessment, there can be frontal lobe signs, temporal lobe signs, but that is like splitting hair. So I look at the overall picture. She's working, she's on her own, which I've seen similar accidents, vegetative state, who are on ventilator, cared for years together. They're on ventilator unconscious. So when you see that difference, you're very happy for that. And yeah, maybe she may not get a Nobel Prize, but none of us will get anyway. So, but she's able to work, she's able to maintain a family, she's married now, she has a husband, she'll be having a child in due course. So her functions are all fine. She didn't have periods for 1.5 years to 2 years. But then that was all part of recovery phase. And then now, after that, she got her periods, she got her, her ovary, the ovulation cycle came back to normal. Her mentality, she didn't have words started coming. So the good thing about the brain is there are certain areas that take the function of another area. It's like a huge, factory when there's one person dominantly looking after the factory and he suddenly resigns or passes away. There's going to be a havoc in the factory because there's nobody else to take up. But at some point, somebody will take up function and bring it up. So brain has, that's called recruitment. So brain recruits cells. And plasticity is one aspect where brain takes the function completely. So up to 5 years of age, if you have say a birth tumor or a trauma in the speech area, another area will take over the speech. But that is only till 5 years, 4 to 5 years. After which that plasticity won't be there. But other functions are taken over by the surrounding areas of injury, which we have prevented because we are going to prevent secondary injury. Primary injury is the brain that came out. But the secondary injury is what we are preventing, where cells, some component of that cell is remaining here, which will take over the function of that in due course. It's a learning mechanism. And they learn, like she was a child throughout. She was like a baby, word by word. A, B, C, D, she had to start from. And then she finished her engineering after that. But it was faster because slowly her old memory came back, her old teachings. So when she started relearning, she was learning much faster. And she was able to make it. Yeah. Yes. Reason. This area is the thinnest bone. And below this area, there's something called a middle meningeal artery. That is an artery that supplies the dura. So that fracture can cut through that artery and it won't bleed out. If it bleeds out, you'll see a big swelling. You must have seen in children having fallen, a huge swelling. That's bleeding out, we would. Same bleeding inside, you can't see any swelling. It keeps on growing inside. And as it grows, first you'll become semi-conscious, unconscious, and then you go and sleep after that. There's no way of assessment. So that's called lucid interval. So that sort of thing can happen. Or it can immediately happen if the artery ruptures. Immediately, patient can have blood. Within 2 to 3 hours, he can die. That also can happen. There are fractures. The fractures can continuously bleed inside, slowly. So they collect blood over the period of time. And if lucky, they'll complain of headache, we come and do a CT and we see this can immediately operate over it before the brain decompensates. The brain is so fascinating, it compensates to a large extent. After a point, it decompensates. We have to catch them before that decompensation phase. Then things are good. So small injuries can contribute, but it will not cause major issues. It's only large quantum of cells are involved. There is an issue. As I told you, how many billion cells? 1 or 2, 3 goes, it doesn't matter. But when it's cumulative, large quantities, then the issue comes. So small bangs, in an elderly person, you have to be very careful because as I told you, there's a space between the brain and the dura. So that space can bleed slowly. So I've seen patients who come with weakness and they have not told we have had trauma at all. There's no history of trauma, but the scan shows a chronic blood. We remove it and then they remember. Yeah, I remember when I was getting up, my head hit the roof was, some ledge or something like that. That was 2-3 weeks back. So that 2-3 weeks was the time for it to gradually increase.
In continuous Saumitri's question, one part is by skull, lateral part, another one is lateral base.
Base.
So that is also only anatomical reason.
Yes, because brain stem, which is very, very important, is right.
And the spine also coming very near there.
This cervicovertebral junction.
These are 2 areas we have to be more cautious about. And also, I think about 30-35 years ago, many people happily when small infant comes there, we used to shake them. They used to laugh at them.
And throw them and catch them.
Yes, baby shaking syndrome.
Yeah.
Mother, he said about 15 years later, we realized then 35 years later, them not to shake the baby.
Yeah.
Make them happy and laugh. Don't do this. So this is what we called American Academy of Pediatrics. Yes. Thank you for that.
That's a spontaneous reaction. You're not doing it to do anything to the baby. It's just that you see him gurgle and laugh. I do that and more laughter. You're happy, baby is happy, but then things are happening inside.
That's right. Second thing now, right brain, left brain. A lot of things are there anatomically, we cannot really prove it. Right brain is only subconscious. You think of that thinking process and writing stories and all this.
So, your imagination, your artistic trend, your literature, comes right. But your logic, your statistics, everything is left. So some people you must have noticed.
Combination. But subconscious and conscious would you among the same thing, right brain, subconscious?
Really, we don't know the seat of consciousness. We have no idea.
No idea.
It could be anywhere. Yeah. That is another fascinating thing which we have not localized. There is no imaging that can pick up your subconscious. Your consciousness is here. The rest is anatomy. That is consciousness. So there's nothing to prove your consciousness. We have really advanced in neuroimaging for the past 2-3 decades. Phenomenal leaps and bounds. So we have something called functional MRI, where when you laugh, one particular brain highlights. So that's a laughing area. Or when you're completely happy, there's more vascularity. When you're sad, vascularity shrinks, which will cause more dirt. So if you're happy, you're jovial, you're laughing, you do those things, it's energy to the brain. You're sad, you're depressed, you're angry, then it causes vasoconstriction, and lack of blood supply causes cell death. subtle, very minute, but it happens. That's why always be happy. But this laughter therapy and all, you should really feel the laughter, not just ha 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 ha, it doesn't work. You have to feel the laughter. So maybe you attend a joking session or a stand-up comedy when you laugh from within or crack a joke and laugh. It's different from just 5-10 people standing around and ha ha ha. It happens all over you see nowadays. It should come from within. So it makes a lot of difference. That will help in your maybe your lung and all that. But the happiness quotient is very important. Thrill is very important. All those things can make, it's all like Chyawanprash to your brain.
Any other questions, please? So I think we sincerely thank you for what you have done on behalf of village climate change. I request Professor Srinivasan give a small token of appreciation.
Thank you so much.
So anyway, I do recognize the presence of our past president of the ComHat India chapter, Professor J.G. Rao, and also the coordinator for the international national major coordinator. And we have Secretary General here. I request to give the vote of thanks, sir. Professor Madhu is the professor of pediatric, Kempegowda Institute of Medical Sciences.
Good evening, everyone. It was a good brainstorming session and also a lot of key messages from Dr. Ravi Gopal Verma, sir, eminent neurosurgeon, and also who's working and worked in many institutions and is a big name. So we are very much honored with his presence for today's talk. And I also thank Dr. Professor Srinivasan, sir, our president, Professor Paramesh, sir, our past president, Dr. J.J. Rao, sir, and all the attendees here. I thank one and all. And we, as a part of ComHat, in collaboration with DHA, are very happy to run these sessions, monthly sessions, with a new topic every month to reach everyone. That's the initiative what has been taken from our president. And thank you one and all for attending the program. And a big thanks for guest and speaker. Thank you, sir. Thank you.